So give us a historic perspective, if you will, on the cardiovascular outcomes trials in diabetes.
Yeah, it's interesting. All of the trials in diabetes medications predominantly were targeting, glycemic surrogates.
It's a sugar disease. Let's work on the sugar.
Right. Is it effective in reducing hemoglobin A1C, and do we detect any adverse events? And then there was initially this whole milieu kind of arose around the TZDs, and particularly rosiglitazone in the early 2000s. And there was a seminal meta-analysis that said one of these drugs had increased cardiovascular risk. It actually got a huge amount of publicity. There was a congressional inquiry around it, and the FDA released guidance in 2008 actually mandating that cardiovascular outcomes be done for all new applications for diabetes medications to specifically address whether these drugs cause cardiovascular harm.
So if I can paraphrase that, the FDA was looking for cardiovascular safety.
But they said we'll approve it on glycemia.
On glycemia.
But you have to then prove that it's safe.
Yeah, and in pre-approval there had to be it couldn't be an egregiously harmful, and then they narrowed it down post-approval. But exactly, that you have to show us pre-approval and then even stricter post-approval that these drugs are safe in patients with established cardiovascular disease. So they're saying you have to do a trial in high-risk patients with cardiovascular disease and show that there's not an adverse signal, particularly around heart attack and stroke.
And this is part of the strategy, actually, as Steve Nissen said at the last ADA. They were hoping that this would create a change, because we've been using these agents without proving not only that they're not safe, but that they show a benefit. So the cardiovascular outcome trials were designed to show non-inferiority, and then if it gets to certain thresholds, superiority. And that was his strategy.
But I want to make one comment about that, because I think it's important, and we now are going to talk about drugs that were studied for cardiovascular safety, but in fact may have cardiovascular benefit. But I will say, when you design a study to address cardiovascular safety, so a non-inferiority study, you are not adequately designing a study to say, is this drug beneficial for heart disease? Because there's a lot of therapies, including blood pressure reduction, lipid management, that to do a superiority trial, you have to do a much longer duration trial. So the studies are not adequately designed really to definitively say whether these drugs are beneficial long term.
So that was my question going forward. These are patients, as I understand it, in these studies, that were already patients at high risk, already had established cardiovascular disease.
Absolutely.
Right. Not
Enrich
necessarily
the population with a high-risk population.
Not necessarily the best population to prove that there's an improved outcome.
Well, the Canvas study also had a cohort that was a primary prevention group.
About 35%.
About a third of them. Yeah.
1/3.
But my guess, though, and my initial guess, my intuitive guess, which I think was wrong, was whether or not you set it up to show a cardiovascular benefit, that might have fallen out of the data, but you're telling me it didn't.
Well, I'm just saying, if you want to definitively ask if a drug is beneficial to reduce cardiovascular events, you would design it differently than you would a non-inferiority study, which is how to say a drug is safe. And so I will say it's amazing that we are going to talk about drugs that are beneficial for cardiovascular disease, but if you wanted to study a new exciting cardiovascular drug that would lower heart attack or stroke, you would actually not design it the way these outcome
But the
studies
intent
were
is
designed.
different.
The very cost of and the size and the length of these studies really precluded them being done. So the offshoot of this is now we have data we never had before, because this is most people assumed if you get good blood sugar control, you're going to have cardiovascular benefit, but it hadn't been shown.
But here's the key thing. If you look at, say, cholesterol-lowering trials now, say even look at the PCSK9 inhibitors, they don't reduce cardiovascular mortality. And that's because it's very hard, when you're dealing with atherosclerotic events, it's hard to reduce fatal NMI and stroke in short duration trials on top of optimal therapy. And so even if these diabetes drugs, they could have a beneficial atherosclerotic effect, you wouldn't see it in the duration necessarily of the trials for these cardiovascular outcomes trials. And so I think it's great that we do have some exciting data, but I think it's possible if these trials were done differently or in the future, there may be even better options.
But let me just establish the baseline then. These initial trials were because there was some concern that the drugs might increase
harm.
Cardiovascular risk and cause harm. That's what they were looking for. And they found no
Actually,
change.
none of the trials that have been reported after this FDA guidance actually did show cardiovascular harm. They
But
were
they
either
didn't show
neutral
a
or
benefit.
beneficial.
Right.
And if I understand you correctly, that's because they weren't set up to look for it.
Right, that was not the intent of the design, nor the aim of the studies.